Welcome to Med One Picture. My name is Benjamin, and today I'm going to be talking about colorectal cancer. So, colorectal cancer is the third most common cancer worldwide, and it is commonly seen in people with increasing age, people above the ages of 50 years. But as we're going to see in this video, many things, or there's a lot that comes together when it comes to colorectal cancer, and surprisingly, it is a cancer that even in young people can be found, and most of the times, only about 20% of colorectal cancers originate from genetic susceptions or is genetically carried on, and most of the times it is sporadic. So people get this cancer without even a family history of this colorectal cancer. And we have risk factors that have been identified, things like red meat or processed meat, obesity, alcohol, smoking, and inactivity. We have some of the non-modifiable ones like age, as you increase with age, and this comes with increased exposure to carcinogens for a longer time, family history. If you have a inflammatory bowel disease like ulcerative colitis, which is going to cause more of this cancer compared to Crohn's disease, and then hereditary syndromes like familial adenomatosis polyposis, the FAP, and the Lynch. And then we have some protective factors that have also been identified, like diet rich in fiber. Aspirin has been used in some conditions like the Lynch syndrome. Calcium, selenium, vitamin A, C, E, carotenoids, and plant phenols have been found to decrease the risk. And when we look at other risk factors, sometimes when you do things like a ureterosigmoidostomy, where the ureters are diverted into the colon, it's increased with a high risk for development of this colorectal cancer. That's why nowadays it's not commonly done. So when we look at the pathogenesis of colorectal cancer, this is important because it lays foundation to the approaches in management or understanding different syndromes that are associated with development of colorectal cancer. The first pathway that we want to look at is the adenoma-carcinoma pathway. And basically what is in this pathway is that we have development of adenomas. The adenomas develop into carcinoma. Remember, almost 95% of colorectal cancers are going to be adenocarcinomas. So what happens is that we have a mutation in the APC gene whereby we lose the APC, and the APC is going to act as a tumor suppressor gene. So when we lose the APC, or if we have a mutation of the APC, we're going to have a beta-catenin accumulation, and then the beta-catenin is going to increase the proliferation of these cells of the colon. And when they increase, sometimes we're going to have dysplasia, and then we have other mutations downstream of this pathway that are going to occur. When we have the KRAS mutations, it's going to drive the development of an adenoma. And when you have p53 loss, we're going to, which is the final step, we are going to form a carcinoma. And so we're going to have the progression from normal mucosa to formation of a small adenoma to then an advanced adenoma. That is when we have the adenoma developing greater than 10 millimeters, or if it becomes villous in nature, or if we have high growth dysplasia. And after having or attaining these characteristics, we are going to head on to having a carcinoma forming. Then we have the serrated pathway, and this one is going to occur in what we call the hyperplastic polyps, and the sessile serrated polyps. So the sessile serrated polyps are not going to bulge inwards. They're not going to bud off. They're not going to project into the lumen or project off the mucosa. They're going to appear as if they have a broad base. They're going to appear almost as flat lesions. And this is going to be driven by the BRAF mutations and CpG island methylation. And this is often going to be found in the right-sided carcinomas, colorectal carcinomas, and they're mucinous, and they have MS, and they're MSI high cancers. Then we have microsatellite instability pathway, which is the MSI we have looked at here. The microsatellite instability pathway is going to come when we have mismatch repair defects. So the mismatch repair defects, basically, as DNA is forming, we have mismatches sometimes, and this MMR is all the mismatches are going to be repaired. We are going to prevent accumulation of these defects. We're going to remove them. So when this does not happen, we are going to have slippage at DNA repeats and frame shift mutations. And then we shall have the oncogenic mutations or the oncogenicity beginning right here. So the features is that we're going to have medullary or a mucinous histology. And we have a lymphocytic infiltrate, and they're going to be right-sided. So when you look at these polyps that are coming from the microsatellite instability pathway, most of them are going to be medullary, mucinous, and then they have lymphocytic infiltrates, and they're going to be on the right side. And surprisingly, sometimes they have a better prognosis. But when you look at during the management, when trials were done, they had a poor response to 5-fluorouracil monotherapy, which is found to be the backbone in most of the chemotherapy that is given in colorectal cancers. Then we have the inflammation-driven pathway, where things like inflammatory bowel disease have been implicated. We have chronic inflammation leading to oxidative DNA damage, which leads to dysplasia, and the dysplasia leads to carcinoma. And the risk is proportional to the duration. So when we have more than 8 years of pancolitis, most of the time, or when you have a high inflammatory burden, the risk is going to increase of development of colorectal carcinoma. So, quickly I'm going to pass through the inherited syndromes that are associated with development of colorectal carcinoma. So these are important because most of the times they're going to cause a premature occurrence of a colorectal carcinoma. These people are at a higher risk of developing colorectal carcinomas at even a younger age, and they are also most likely they could actually appear in your examinations. So we're going to begin with the first one, that is the FAP, the familial adenomatous polyposis, and this one is very important. It is one of the first syndromes that were discovered, and the gene APC actually was studied a lot based off of this condition. So the gene implicated in FAP is the APC gene, which is adenomatous polyposis coli. And most of the time what we're going to see is that we're going to have a child with many polyps. And these polyps are going to be over 100 polyps. At least these are thousands and thousands of polyps. And the risk of colorectal cancer in these children is going to be almost 100% by the time they are 40 years. So clues, what could give us a clue is that we have a congenital hypertrophy of the retinal pigment epithelium, desmoids, and osteomas. These are all going to point to someone having a clues that someone might be having FAP. Then the variants, we have the Gardner, the Charcot, and the management most of the time is that we do a prophylactic colectomy. So what we do is that we keep on doing these endoscopies since almost the age of 12, and we keep doing these colonoscopies until then when we can do a colectomy. Then we have the attenuated FAP or the FAP, and this one is going to have a similar presentation, but for them they have polyps that are less. So they have almost 10 to 100 polyps, and they are going to be right-sided polyps. And the cancer risk is going to be higher, but is of later onset compared to the one of the FAP. And then the management also is going to be a colectomy when it is needed. Then we have the Lynch syndrome. Now, the Lynch syndrome is a group of cancers, and Lynch is sometimes known as hereditary non-polyposis colorectal carcinoma. And this syndrome is going to be characterized by having other cancers. So we have the extracolonic cancers, and this is going to be endometrial cancers. This is one of the most important cancers associated with the Lynch syndrome. You're going to have ovarian cancer, gastric cancer, biliary cancer, pancreatic cancer, small bowel cancer, and urothelial cancer. So you're going to find that most of the times that people are going to come with a history of a relative who, maybe 2 or more relatives who had these cancers. So it is going to come from the mismatch repair genes. And when we have a defect in the mismatch repair genes, that is where the problems are going to begin of Lynch syndrome. And the tumors are going to be found in we're going to have proximal colorectal carcinoma. So they're going to be on the right side, and it's going to be of early onset, and most of the time it's going to have this ulcerated polyps, so they are not going to be raised, and there's a high chance of actually missing them when we do the colonoscopy. And the management is that we're going to do an annual colonoscopy almost from the age of 20 to 25, or sometimes we count 10 years from below the person who has the we have relatives of this patient, yes, and these relatives, we see the one who got the cancer at the youngest age, and the youngest age at which they developed the cancer, we subtract 10 years, and 10 years below that, that is when we expect to begin doing our colonoscopy. So if the youngest person got the cancer at 45 years, we are going to count 10 years behind, and then 10 years behind, that will be at 25 years, we shall begin doing our annual colonoscopies. And sometimes the treatment is going to be a total colectomy, because again, when we look at these people, with Lynch syndrome, they are at a higher risk of developing the cancer. So almost 70%. So doing a hemicolectomy or removing just removing just a segment is not going to cut it. These people are still at a high risk. So we do mostly a total colectomy. And the diagnosis is made with the Amsterdam criteria, which has been now replaced by the Bethesda, which is more specific. So the Amsterdam criteria basically puts into consideration the age and family history, whereby we need at least 3 relatives to this patient who have a history of developing cancers that are identified with the Lynch syndrome. Maybe you find the mother had endometrial cancer, the grandmother probably could have had rectal cancer, things like that. And these people have to be in successive generations. And then we also consider the age. If one of them was diagnosed, if the diagnosis was made before 45 years. And there are other parameters within the Amsterdam criteria which you can always look at. Then we have the polyposis syndromes that are with hematomas. So hematomas are these hematomas polyps, or these polyps. So the first one is the Peutz-Jeghers syndrome. And the Peutz-Jeghers is you have the gene that is implicated is the STK11AD. And most of the times we're going to find hematomas and mucocutaneous pigmentation. So what happens is that people with Peutz-Jeghers actually have the ability to develop hematomas almost in every part of the body, from the lungs, the breast, the pancreas, the intestines. So these people have hematomas or polyps all over the body, and then they have a common presentation of mucocutaneous pigmentation. So in your next ones are talking about melanin or mucocutaneous pigmentation or melanin pigmentation on maybe the lips, maybe the gums, or on these mucous membranes. Most of the time it's Peutz-Jeghers. Then sometimes when we find one single or in find polyps since a very young kid, probably at the age of like 10, then we think about the juvenile polyposis syndrome. The genes there we have the SMAD4 and the PMPRL1AD genes. And the findings is that we have multiple juvenile polyps, so they are occurring in a very young kid. And this one have a high risk of developing colorectal cancer as well as gastric cancer. Then we have the Cowden syndrome, which is associated with the mutation in the PTEN. And these ones also are associated with easily getting hematomas, thyroid, and breast tumors. And I have videos on these cancers, the thyroid and breast cancers. And the cancer risk is also moderately high. So, when you look at colorectal polyps come in a number of types, and we have the adenomas, adenomatous polyps, we have the hyperplastic, we have the inflammatory, and we have the amautomatous. So, when you look at the adenomas are histologically going to have 3 types. We have the tubular and the villus, and the tubular villus, as well as the serrated. So, what happens is that we have risks that are associated. Whenever we have a tubular, when we have a villus, it's going to have a more high risk of developing cancer. So what happens is that we have red flags. So during screening or during colonoscopy, we could identify a polyp, and we want to know, is this polyp dangerous or it has a low risk? So most of the time, if it's greater than 1 centimeter, if it is sessile, that is if it is flat, like we have seen in different conditions like Lynch syndrome, If it is villous, when we do the histology, or if it has hydrodysplasia or an ulceration, this is going to be a red flag that probably this polyp is a pre-malignant lesion. And the location, if it is right, it's going to be most of the time on the right, we are looking for serrated or flat. Then on the left, they are most likely going to be hyperplastic, which means they are big, or they are protruding into the lumen, or they are pedunculated. And then the surveillance. If we have 1 to 2 small polyps, we may continue doing 5 to 10 yearly endocolonoscopies. Then when we have more than 3, or if we have a villous polyps, or if we have polyps that are greater than 10 millimeters, or if we have high-grade dysplasia, we're going to do it 3 yearly. And that takes us now to the screening. So when we are screening, we want to first find the risk. We want to risk stratify the patient. Is there an average risk patient or a high risk patient? Average risk patients went from 45 to 7, where they're the ones that are running from 45 to 75 years and have no family history. They have no adenomas. They have no those high risk things that we have looked at. And we are going to do a colonoscopy 10 yearly, or we can do the fecal immunochemical test yearly. And this one we somehow has been improved. We have the DNA and the feet combined together. And we can do this one 3 yearly, as well as the CT colonography, whereby we take a spiral CT scan, and then there is a 3D reconstruction of the colon to see the anatomy inside the colon. We can identify polyps and everything like that. And with this, so if we have a positive, this we call them the non-invasive test. So if we have a positive non-invasive, then we are going to proceed to do the colonoscopy, which is the gold standard for diagnosis of colon cancer. We're going to proceed to do that and visualize the polyp. Then we have these people who have an increased risk. For example, the people we have seen who have a first-degree relative who has had colon cancer. So if the first-degree relative got it below 60 years, at exactly 40 years, we want to start doing screening 10 yearly. We want at exactly 40 years, we want to start doing the screening. And sometimes we may consider 10 years before the age of diagnosis of a cancer in their first degree relative. So if for example, someone's mother had the cancer at 40 years, we may consider starting the screening for that patient or that person 10 years earlier, that is at 30 years. And we shall do it every 5 years. Then if we have people who have like inflammatory bowel disease, we may consider doing it 8 yearly. If they have had pancolitis for 8 years, or if we have 12 to 15 years of left-sided colitis, that is in ulcerative colitis, then we want to start doing their colonoscopies 1 to 3 yearly. So we can do it 1 yearly or every 3 years. Then in Lynch syndrome, we want to begin at 20 to 25 years. And we shall do it every 1 to 2 years. Then in FAP, we want to begin also at 10 to 12 years. We want to do it annually because these people are at a very, very high risk. And for FAP, we want to do the screening until the time when we can do the total colectomy. And most probably this patient is going to remain with a stoma for life. Then we have surveillance. If we have 1 to 2 small tubular adenomas, then we are going to do it 5 to 10 years. If we have more than 3, and if they are villous in nature, or if we have a villous a polyp, if we have high-grade dysplasia in a polyp, or if the polyp is greater than 10 millimeters, then we want to do it 3 yearly. Then if we have someone post-colorectal cancer, 1 year, we want to do it at 1 year, we want to do it at 3 years, and then we want to do it 5 yearly. And then when we reach about 85 years, sometimes we stop. And between 75 to 85 years, we individualize. We can decide to continue or we can decide to stop the screening. So we have the clinical presentation of colorectal cancer. And most of the time, we're going to have a general presentation that is common. Then we can have features that are associated with right-sided colorectal cancers and left-sided colorectal cancers. And the difference is going to come between the size of the lumens and the kind of cancers that develop there and the kind of fecal matter that is there. So when you look at the right side of the colon is actually bigger compared to the left side. And most of the time, it has more fluid fecal matter than the right side. So when we look at our general presentation, most of the times we have a change in bowel habits, and this is a typical presentation in colorectal cancers. We have a change in bowel habits, then we have GI bleeding, weight loss, abdominal pain, anemia, and most common it's iron deficiency anemia, as well as tenesmus, which is a feeling of incomplete emptying. Someone feels like they're not defecating fully. Then when we have right-sided colorectal cancer, sometimes we have what we call occult bleeding, whereby the blood is not visible in the stool. And then we have someone developing iron deficiency anemia, they have vague abdominal discomfort, and they have a palpable mass sometimes. And the problem with this is that most of the time it's going to present late because of the size of the lumen. So we don't get symptoms early. I mean, when the symptoms early, the patient is going to come when actually the cancer has gone too far, when we have a progression in the stage of the cancer. Then when we have a left-sided colorectal cancer, most of the times you have this visible bleeding because if of the kind of polyps that are actually going in the left side, we have these hyperplastic or the pedunculated ones. So what happens is that the lumen is narrow, the fecal matter is also solid. So as it's passing there, it's going to erode on these polyps or on these cancers, and most of the time we're going to have bleeding. So visible bleeding may be seen. Then altered bowel habits, constipation, because as these things are growing into the lumen, they are occluding the lumen. So constipation is going to begin. These people are going to get constipated, and sometimes when they go and force and they try to, use Valsalva, they may end up pushing the fecal matter into that narrow lumen, and we have what we call the pencil thin stools, where the stools to pencil thin, and then we can have complete obstruction, and then we can have tenesmus, which is the feeling of incomplete empty of the rectum after defecating. Then we can also have the signs of metastasis. Someone may present with the most common metastasis in this colorectal cancer go to the liver, because when you look at the venous drainage of the colon, is most of it going to go to the liver through the portal system. So they're going to present with hepatomegaly, they're going to present with jaundice, right upper quadrant pain. It's to the lungs, they're going to have cough, pulmonary nodules. This is the ovarian, they're going to have Kuchenbach tumors, that's the pelvic mass. Then peritoneal carcinomatosis is also common. And the red flags that are warranting urgent colonoscopy, however, an elderly patient who has any of these, you want to actually do a colonoscopy. That is iron deficiency anemia, persistent rectal bleeding, a change in bowel habits in people greater than 40 to 50 years, weight loss, and then a family history of early onset colorectal cancer. Then if you do the fecal immunochemical test, it is going to be positive. So the fecal immunochemical test is like a fecal occult blood test, but instead of using a stool quack, this time we use a more sensitive or something that we check for the proteins, the hemoglobin itself, because the fecal occult blood test is kind of prone to getting more. The sensitivity is less compared to the feet. So the diagnostic workup, primarily you want to do a colonoscopy on the biopsy, and you identify and can tell what's going on. In pathology, most of the time we have adenoma-carcinoma, 90%, 95%, and you can have a mucinous, or the signatory type, and the signatory is going to have a poor prognosis. Then the grade, we want to grade the cancer. If we want to check for vascular invasion, perineural invasion, and almost always we have to always request for the status of these genes. We want to see the MMRI or the MSI status. This is the mismatch repair status. The KRAS, we want to see, are they KRAS positive, are they NRAS positive, are they BRAF positive. We want to find out all those things because they're going to affect the management. And the staging investigations, we can do the CEA, which is can get a baseline, and the CEA is not diagnostic, but it is prognostic. It's going to help us with the uh, with the prognosis of the cancer or our response to therapy. Then we can do CT of the chest, abdomen, and pelvis, so what we call a pan-CT scan to check for metastasis. Then we can do for rectal cancer, we may do MRI of the pelvis and of the mesorectal fascia, and then the rectal ultrasound for superficial lesions. Then you want to consider a PET-CT for equivocal lesions or surgical planning and metastastectomy, which is the cutting away of the metastasis if possible. Then the staging, we are going to use the TNM. T1 if we have the tumor at the submucosa, T2 if we have the tumor at the muscularis propria, stage T3 through the muscularis, T4A serosa, T4B adjacent organs. Then the nodes N1, 1 to 3 nodes, N2 for middle and 4 nodes, and then metastasis, we have M1 to a single organ, M1B to multiple organs, and M1C to the peritoneum. So the management, if we have a localized colon cancer, treatment is the primary target. And we can do a right hemicolectomy if it is on the right, a left hemicolectomy, we can do a sigmoid colectomy, and we must always do high ligation of the feeding vessels and lymphadenectomy whenever we are doing this. So ligation has to be done always. Then we have to give adjuvant chemotherapy most of the time because you want to make sure we improve. So when we have stage 3 cancer, we do the FOLFOX, which is folinic acid with 5-fluorouracil and oxaliplatin, and this is the standard mostly used. And if it's stage 2, if we have MSI high, then we have no benefit from 5-fluorouracil and we avoid unless we have a high risk. Then high risk features, when we have high risk features, I mean T4, when you have perforation, obstruction, and when we have more than 12 nodes, we want to still offer the chemotherapy. So metastatic disease, sometimes you can do metastatectomy, where we can do it in the liver or the lungs. If we can be able to actually resect and get an iron node margin, then we can attempt that. Then as well as we can follow a systemic therapy with 5-fluorouracil backbone, and we use targeted agents like the anti-EGFR, anti-VEGF, and when we have BRAF, most times it has poor prognosis. And then we can do immunotherapy for MSI, that is pembrolizumab or nivolumab. So we have come to the end of this video, and there's a lot we have covered, a lot about the screening modalities as well as the pathogenesis and epidemiology, risk factors of a disease. And I hope as of this has made sense now. I hope you liked the video. If you did, please leave a like, leave a comment. You can share this video with a friend. My name is Benjamin. See you next time.